Good morning, everybody. Welcome to our final day of this year's late summer school for ultrasound. I hope you had a fantastic time so far and you learned a lot and you enjoyed your time with us. To everybody, to all of the participants who went to our social evening yesterday, I also hope you enjoyed that. Thank you for this extra hour, right? That came in handy. I would also like to address a very warm welcome to everybody watching by live stream and to all our students from our partner universities. Thank you for joining us once again. We got to know the eFAST exam and the Rush exam during the previous days, and today we're going to move on to more advanced ultrasound applications. That is lung sonography and ultrasound in cardiac arrest. We switched both of our speakers for today. They are a little bit different in the program, and that's due to geographical reasons, because Dr. Felipe Terran is actually streaming live from Philadelphia today. So, before we start, it's my pleasure to introduce you to Julia Kraner, who's going to talk us through the Rush exam. And she's going to be accompanied by Sharon and Patrick.
Ich brauche aber zuerst die Präsentation. All right, good morning, everyone. It's a pleasure for me to welcome you to the last day of the summer school. Obviously, we have lost some people along the way yesterday evening, I guess. But still, we're going to talk the Rush exam that you practiced yesterday. And first of all, I know that my dear colleague Romeo told you a lot about romance yesterday. And my name is Julia, but I'm not that romantic person, actually. So if we talk about the Rush protocol, I hope that during the last few days, maybe we helped you get a little bit attached to sonography, and maybe you have fallen a little bit in love. But what we actually want is help you build some sort of lifelong lasting relationship to ultrasound. So I think that we need a little bit more than just romance, all right? So romance, of course, is an important part. Also, if we talk about the Rush protocol. And if we talk about romance, it was the eFAST yesterday. And for Rush, we refer to this as the tank. And as I said, I think we need a little bit more than just romance. I think we need a little bit of the heart. So we include the pump. And what we also need is some sort of connection, communication, giving and taking. And this is actually the pipes, all right? So you see we have the pump, the tank, and the pipes. And together, there are the pillars of our Rush protocol. All right? So, first of all, I want to recall for you what we actually need the Rush protocol for, because I think there's no use if you know how to do the exam, but do not know what we actually use it for. So, I'm pretty sure you remember that the Rush exam, we use it in shocked patients. And shock actually is a sort of lack of blood circulating in the body, resulting in a lack of nutrients and oxygen propelled through and getting to the organs and different parts. And if we see a shocked patient, very often we do not initially know what the problem is, right? Because there are different types of shock. It could be something wrong with the volume. Maybe it's not in the right position. It could be somewhere in the body. If there's some gastrointestinal bleeding, it is still in there, but not useful. So it could be a hypovolemic shock. It could also be lost through diarrhea or vomiting. Or it could be somewhere lost down in your legs due to vasodilation, so it's not of any use. But if there is enough volume, and it is in the right position, there has to be something different wrong. So maybe there's something wrong with the pump, and it cannot be propelled through the body. So maybe there's a cardiogenic shock. Or maybe there's an obstruction along the way due to some pulmonary embolism or a pneumothorax, a tension pneumothorax, or pericardiac tamponade. All right, so we have to differentiate those types of shock, and for this, we use the Rush protocol. So I want to talk about the different parts of each pillar, and then we'll demonstrate some of the parts for you. All right? So if we talk about the pump, you have to have your questions in mind that you want to get answered, right? So the first question is the heart pumping actually? Is it working? Is the left ventricular function all right? Second question is, what's the size of the right ventricle in comparison to the left one like? So maybe there's something obstructing in the pulmonary circulation and the heart gets dilated, so it would be the same size of like the left ventricle, and you would know there's something wrong. And the third question is the pericardial effusion, all right? And for these three questions, we have 4 views of the heart. So I'm pretty sure you remember the parasternal views, the long axis, as well as the short axis. We have a subxiphoid view, as well as a apical 4-chamber view, okay? So the second pillar is the tank, and I'm pretty sure you remember the EFOS protocol, so I will not talk a lot about this today. You remember you use it to exclude some free fluid in the abdomen or thorax or a pneumothorax, okay? But what we also need is the supply of the tank, of the pump, and this is the vena cava, the inferior vena cava. So we will talk a little bit about that, okay? And then there's the last part, and these are the pipes. So the pipes are the veins and arteries, and you will hear a lecture on excluding a deep vein thrombosis, so we'll not talk about that and focus a little bit more on the aorta, all right? So now you know the different parts of the Rush protocol, and now we will show you some of them. So we'll start with the heart. We'll start with a parasternal long axis view, and you remember, you take your probe, it's a sectoral probe, and you put it right next to your sternum on the left side, rotate it so that the marker of the probe points toward the patient's left shoulder. And then you can see, what can you see? You can see the left atrium, mitral valve, you can see the left ventricle, you can see the aortic valve, probably a bit of the ascending aorta, and you can also see the right ventricle. Oops. All right. And you have your questions in mind, so you can already answer some of them. You can answer the question, is the pericardial effusion? Maybe if it's a large effusion, you would see the fluid as an anechoic structure around the heart, like wrapping it. If it's just a small one, you could see it right underneath the right ventricle, in between the ventricle and the descending aorta, which you see as a round echogenic structure, an echogenic structure down there. So, all right, you can also see if it's pumping properly, if it's contracting. You can see the right ventricle, but if you want to get the question answered if it's dilated, we rotate in a parasternal short axis view. So rotate on the top, so you leave it there and rotate it 90 degrees clockwise towards the patient's left shoulder, and you can see the left ventricle as a very round structure, contracting circumferentially. You can see right here, you can see the mitral valve, you can see the right ventricle, tricuspid valve. And you can also see the right ventricle up there, okay? If it's dilated, the right ventricle, you would see a shift of the septum so that you would get the D sign, all right? So the left ventricle would no longer be that round. Then we have another view. You remember this one, the parasternal, the subxiphoid view. We already had in EFOS exams, we will not repeat it again. We will do the apical 4-chamber view. So you put the probe right at the point of the maximum impulse of the heart, all right? And you can see the 4 chambers of the heart. Closest to the probe, you see the ventricles, the left ventricle and the right ventricle. Exactly, and you can get an overview of the contractility of the heart. You can see pericardial effusion, or if there's something wrong with the walls, for instance. All right. Okay, so you have in mind the EFAST exam, so we will just focus on the vena cava inferior. And you use this to evaluate the fullness of the tank, if there's some fluid lacking or not, because very often you have to decide, should I give the patient fluid or not? So if you see the vena cava, you want to know, is it collapsing in inspiration or not? Because usually, due to pressure changes while inspirating in the thoracic cavity, it would collapse. So usually it should collapse at least about 50%. If it's not, you would know that probably there's something obstructing in the pulmonary circulation. All right? So you see that anechoic structure down there, which is the vena cava inferior. Okay, so this is the next questions that we answered. And then there's the last question concerning the pipes. So you want to answer the question if there is an aortic aneurysm that could have ruptured, it could cause bleeding, so a hypovolemic shock probably. And you can do this by evaluating through the parasternal long axis view. You saw the root of the aorta. But now we want to see the aortic arch. Yeah, exactly. Here again, you can see it. And if you want to evaluate the aortic arch, you have to do a suprasternal view. All right. And you can see the different branches of the aorta. You can see the brachiocephalic artery. You can see the common and carotid common artery of the left side and the left subclavian artery, usually. And then you have to evaluate the abdominal aorta. You have to evaluate it right underneath the sternum and all the way down till the iliac bifurcation around navel height. So you see the liver, you do it in a transverse view. You can see the vertebral body, you can see the inferior vena cava, and then you go down all the way. You have to make sure that you apply some pressure, otherwise you may not see it due to bowel gas. And then you can see the aortic bifurcation. All right. So I hope you have your rush examination in mind. You have your 3 pillars, pump, tank, and pipes. And you have to make sure that you answer the questions according to the clinical question, okay? So you can use those those views to answer your question in mind. All right, so that's it for the rush protocol, and I hope you enjoy your last day of this year's summer school.
Thank you so much, Julia. Thank you so much. And also thank you to Sharon and Patrick. You've done a great job too. We're now going to take a 10 minutes break, otherwise we're ahead of schedule, but we're going to continue at 10:30 sharp, please. Thank you.